For decades, the medical establishment and society at large viewed excess weight through a punishing lens. If you were heavy, you were placed in clinical, almost interrogatory environments and told that you simply lacked discipline. The medical consensus largely treated severe obesity as a moral failing rather than a complex biological condition. Because the prevailing theory pointed to willpower, a massive multi-billion-dollar industry rushed in to fill the gap. Generations of people cycled through intense fitness fads, extreme restriction plans, and shelves of paperbacks promising permanent results. And time after time, on a macro level, the population only grew heavier. A specific class of medicines finally disrupted this cycle. Researchers originally engineered these molecules to solve an unrelated health problem, and their impact on weight was discovered entirely by accident. We spent half a century trying to treat a deeply entrenched biochemical state using psychological tools. It took a medical accident to show us we were fighting the wrong battle all along. The medicines driving today's headlines are known as GLP-1 receptor agonists. When researchers first developed them, weight loss wasn't even on the radar. They were strictly designed to help patients with type 2 diabetes manage their blood sugar levels. Then, doctors began noticing a striking pattern in their clinics. Their diabetic patients were shedding serious mass, sometimes up to 30 kilograms. They were achieving results that previously required invasive gastric bypass surgery, simply by taking their weekly medication. Word leaked out and demand erupted globally. Specific injectable brands like Ozempic, Wegovy, and Mounjaro suddenly flooded the market. Tech billionaires, Hollywood celebrities, and politicians rapidly adopted them, turning a specialized diabetes treatment into a worldwide cultural obsession. To figure out the true medical reality of these injections, we have to look past the red carpets and the media hype. We need to examine how these injectable molecules reconfigure the body's internal signaling. Inside your body, GLP-1 is a naturally occurring hormone. After you eat a meal, your intestines release it to tell your pancreas to produce insulin, and to tell your brain that you've had enough food. These new drugs are synthetic mimics of that exact hormone, chemically designed to survive much longer in the bloodstream. Binding to natural GLP-1 receptors, the medication tricks your system into an artificial state of fullness. It attacks appetite from two directions, slowing the rate your stomach empties food and crossing the blood-brain barrier to mute neurological hunger signals. The clinical results are staggering. Trials show individuals reducing their total body weight by an average of 15% or more. With that mass gone, doctors are seeing direct, sharp drops in severe complications like high blood pressure, fatty liver disease, and sleep apnea. By chemically turning off the urge to eat right at the receptor level, these molecules proved what researchers had long suspected. Severe, chronic obesity is a deeply embedded hormonal and metabolic disease. But altering the body's natural signals always invites pushback. Because the digestive system is physically slowed down, the most frequent side effects are harsh gastrointestinal issues. Nausea, intense vomiting, and severe bloating are common enough that many patients abandon the treatment entirely. There is also a hidden structural risk. When a patient sheds weight that rapidly without meticulously managing their protein intake and strength training, the body doesn't just burn fat, it consumes its own underlying muscle mass, leaving the patient significantly weaker. Then there is the timeline. These drugs are new to the mass market. The medical community currently has zero data on the physical consequences of preserving these artificial signaling states for 30 or 40 years. Because the underlying genetics and environment remain the same, stopping the medication often results in the weight returning. For most, this marks the start of a lifelong chronic disease management regimen. The sheer scale of that lifelong commitment has sent shockwaves far beyond the clinic. Pharmaceutical manufacturers are experiencing record financial booms, racing to patent and monopolize what is rapidly becoming the most lucrative new sector in medicine. But that explosive growth has fractured the supply chain. Extreme off-label demand for weight loss has stripped pharmacy shelves bare, leaving actual diabetic patients unable to access the very medication they rely on to survive. The ripples are spreading out into entirely unrelated sectors. A medically induced drop in human appetite is forcing the global food and beverage industry onto the defensive. Mega corporations that rely heavily on the continuous consumption of highly processed, impulse-driven snack foods are suddenly facing a consumer base that simply isn't hungry anymore. The math gets even stranger. Analysts in the airline industry have started modeling how a slightly leaner general population could directly alter corporate fuel-saving projections, reducing the massive kerosene costs required to lift millions of passengers into the sky each year. Engineering a chemical reduction in how much we consume threatens the base of any global industry built on constant, unchecked eating. Yet all of these sweeping changes hinge on a single restrictive factor: the price. The exorbitant monthly cost of these injections threatens to fracture healthcare access, turning effective obesity management into a luxury reserved exclusively for the wealthy. Despite the cost, the momentum is unstoppable. Competitors and even more aggressive next-generation drugs are already moving through clinical trials. This biological intervention is no longer an anomaly. It is a permanent fixture of modern medicine. As these medications become more common, they are challenging long-standing medical assumptions about willpower and forcing a reevaluation of how we define metabolic disease. Science has found a way to chemically dismantle the human drive to eat. We have conquered a fundamental biological instinct, but we are only just beginning to reckon with the medical, financial, and ethical consequences